Welcome to Module 7, Modes of Ventilation, Setting Selection and Adjustment of the Biphasic Kuros Ventilation Bootcamp. In this module, you'll learn about available modes on the Hayek RTX, the physiologic effects of each mode, indications for each mode, starting settings for each mode, precautions and considerations. Standby or monitoring allows monitoring of the patient's respiratory activity with no therapeutic effect. Continuous negative mode. Physiologic effects increases the functional residual capacity by creating a continuous negative extrathoracic pressure while the patient is breathing spontaneously. Affects alveolar recruitment, small airway dilation, increased alveolar capillary perfusion, decreased work of breathing, improvements in ventilation and perfusion matching, and enables more effective spontaneous ventilation. Indications for continuous negative: recruitment of alveoli and small airways, atelectasis, hypoxemia, increased work of breathing, allows for reduced mean airway pressures during positive pressure ventilation, allows utilization of decreased PEEP when patients are on positive pressure, to reduce the potential for lung injury during positive pressure ventilation, improves lung compliance and resistance, and facilitates weaning from positive pressure ventilation. Starting settings in the continuous mode: adults -8 to -15, pediatrics -6 to -10, infants -4 to -8, and in extreme alveolar recruitment or hypoxemia, -20 or even more negative for certain patients. The pathway to access is menu, accept mode selection, highlight the mode you require, press accept, set or check the parameter settings. Once all verified, accept, be sure to touch start stop to activate the mode. Parameter settings can be altered at any time during ventilation without interrupting therapy by pressing menu, parameter settings, input your appropriate parameter adjustments. Once all input, accept. Please note these starting settings are recommended based on a wide range of patients with different disease processes. These starting settings may not always be applicable for the specific age groups. Titrating to higher pressures may be needed. Discernment is necessary to determine appropriate settings based on individual case. Precautions and considerations for continuous negative. Patients must have an adequate respiratory drive. There is no backup rate in continuous negative, so patients must have a competent and intact respiratory drive. There is a potential for monitoring for apnea, but recommendation is to have an intact respiratory drive. When used with positive pressure, it may require decreased PEEP. The continuous negative and PEEP are additive to FRC, and increased FRC beyond a certain point may create increased pressures with tidal ventilation during positive pressure ventilation. Continuous negative works well for most early hypoxemic and hypercarbic respiratory failure cases. Control mode. In control mode, it is a ventilator. We're setting a negative pressure to create lung inflation, a positive pressure to generate exhalation, setting a rate and an IE ratio. It is a non-invasive ventilator. Controlling both phases, inspiratory and expiratory, while providing full control for rate and breath timing of supported breaths. Control mode supports increased minute ventilation, also supports spontaneous breathing with a bilevel pressure wave, capable of full support of ventilation, alveolar recruitment, small airway dilation, improves alveolar capillary perfusion, decreases work of breathing, and enacts improvements in ventilation and perfusion match. Indications for control mode are a weak or absent respiratory drive, CO2 retention and dyspnea that has not responded to continuous negative titration, and it can be used with positive pressure when the positive pressure ventilator is in the assist mode with rate set less than VCV rate. Starting settings for control mode: adults -21 inspiratory plus 7 expiratory. Pediatrics -18 and +6. Infants -12 and +4. Setting starting respiratory rate about 2 above normal for age. IE ratio start at 1:1. Precautions and considerations in control mode. Mean Kuros pressure should always be kept more negative than -4. This average mean pressure is very important to monitor, and in control mode, if less negative than -4 or positive, will create deflation of the lungs. By maintaining mean Kuros pressure more negative than -4, inflation is always favored, and expiratory lung volume is always managed above FRC. At rates above 60 cycles per minute, inspiratory and expiratory pressures and timing should be balanced. So if that rate elevation is required for CO2 clearance, at that point, it is time to balance your pressures. So if you're generating a pressure difference of 30, you would divide that up as 15 over 15. Keep your IE ratio at 1:1. Thereby, you're not enhancing air trapping. So by balancing the pressures, we're not favoring inspiration quite as much, and we're going to help empty the lungs more. Control mode works similarly to IMV in positive pressure ventilation, as the patient can take unsynchronized and unsupported spontaneous breaths between the time-cycled machine breaths. That's basically how BCV works. The patient can breathe spontaneously at both pressure levels as long as they need to or as long as they choose to, but generally patients allow the device to take over the work of breathing and they relax and let it do the work for them. Pressure differential, delta P or span, is the mathematical difference between the negative and positive pressures. This variable affects tidal volume. Delta P should always exceed at least 10 centimeters of water pressure. Generally, it'll be twice or triple that. To decrease arterial CO2, increase the rate. Increase the delta P or alter the IE ratio into a 1:1.2 or 1:1.5 from the original 1.1, or apply all these simultaneously. Control mode precautions and considerations continued. To increase PaO2 or SpO2, make mean Kuros pressure more negative. This is how we affect oxygenation with the Hayek. The mean Kuros pressure is a surrogate for index respiratory lung volume, similar to a peak value that you might see on positive pressure, more probably the mean airway pressure, but this is the average of pressure within the Kuros itself. It's not airway pressure, but is a direct reflection of how much index respiratory lung volume is being left in the lungs. As we decrease the mean Kuros pressure to a more negative mean value, we increase the index respiratory lung volume and increase the transfer of oxygen into the lungs. So in order to decrease mean Kuros pressure, you want to alter the IE ratio to a more negative balance. Because we have an active expiratory phase, utilizing these inverse, what would traditionally be considered inverse values, will not harm the patient because we have active exhalation helping the patient to clear that prolonged inspiratory time, breath out with positive phase. To decrease mean Kuros pressure, you can also adjust peak inspiratory pressure to a more negative value or decrease the expiratory pressure. At rates above 60, balancing pressure and timing is recommended, as stated previously. At frequencies of 240 to 1200 cycles per minute, one may only preset frequency and inspiratory pressure. Timing is not adjustable. Respiratory triggered mode. Physiologic effects of respiratory triggered. It provides patient inspiratory triggered ventilation with a set IE ratio. Increases minute ventilation, alveolar recruitment, small airway dilation, increases alveolar capillary perfusion, assists with decreasing work of breathing, and patients experience improvements in VQ matching. Indications for respiratory triggered: CO2 retention and dyspnea that's unresponsive to continuous negative titration, adequate respiratory drive, but with need for breath-to-breath assistance of supportive tidal volume that improves with a set IE ratio. Starting settings in respiratory triggered: adults -21 peak negative inspiratory pressure and +7 peak positive expiratory pressure. Pediatrics -18 and +6. Infants -12 and +4, with a starting IE ratio typically at 1:1. Sensitivity should be set around 5 and adjusted to achieve maximum synchronization with the patient's respiratory effort, regardless of which sensing mechanism is being used. Precautions and considerations in respiratory triggered: pressure differential, delta P or span, which is the mathematical difference between the values, affect tidal volume. Delta P should always exceed 10 centimeters. The patient's spontaneous rate or backup rate determines the frequency. IE ratio is set to decrease the arterial CO2, increase the delta P, or alter the IE ratio to 1 to 1.2 to 1 to 1.5. To increase PaO2 or saturation, make mean QROS pressure more negative, alter I to E ratio to 2:1 or 4:1, adjust peak inspiratory pressure to more negative, or decrease expiratory pressures. Precautions and considerations: if apnea occurs, RTX defaults into the backup rate at set pressures. Airway triggering is accomplished either through sensing through the QROS shell or via the patient's airway. Airway triggering can be achieved by airway pressure sensor tube connected to a nasal cannon placed at the patient's nostril or mouth. The sensor can be taped inside of a tracheostomy mask over the opening of the tracheostomy to measure the pressure wave so the machine can cycle with the patient, or a standard type T airway adapter with a pressure sensing port connected directly to a tracheostomy can be fed back to the device so the machine can trigger with patient efforts. Additional precautions and considerations: pressure waves on the graphic display must be visible to assure a reliable and consistent triggering. It must have a good, even pressure wave to get good, consistent triggering. Sensitivity range for the triggering sensing is 1 to 9, with 1 being most sensitive and 9 being least. This is a scale of range, not a specific amount of pressure. QROS triggering is the first choice for sensitivity. Due to less apparatus, there is an airway adapter required. Airway triggering, however, is more sensitive, working for more patients. Starting sensitivity is set at 5 and adjusted for maximum synchronization. Airway triggering should be selected for patients who are unable to synchronize with QROS sensing. Trigger percent reading should be 85 to 100%. Adjust sensitivity to achieve this. Additional precautions and considerations of respiratory triggered: prolonged periods less than 85% generally indicate a need for increased sensitivity, unless apnea or pauses are observed. Prolonged periods of trigger percent at 100% indicate that auto-triggering may be occurring, suggesting the need for decreased sensitivity. Minimum backup rate is 6 per minute. Maximum backup rate is 60 per minute. Set backup rate at about half of what patient is breathing after they're settled onto support. Backup breaths will not synchronize with patient timing, and it is desirable that the patient trigger each breath if possible. The shallower the patient's breathing, the more sensitive the trigger sensing should be to capture their respiratory effort. Because the RTX is controlling the inspiratory time, patients may develop asynchronous breathing. Should this occur, consider respiratory synchronized. Respiratory synchronized mode. Physiologic effects: increased minute ventilation, increased alveolar recruitment, small airway dilation, increased alveolar capillary perfusion, decreased work of breathing, and improvements in ventilation and perfusion matching. Indications: CO2 retention and dyspnea that were unresponsive to continuous negative titration. Adequate respiratory drive with the need for breath-to-breath assisted support of tidal volume. And persistent patient ventilator asynchrony in control mode or respiratory triggered. Starting settings for respiratory synchronized are similar to the other biphasic modes, with adults -21 peak negative inspiratory pressure and +7 peak positive expiratory pressure. In pediatrics, -18 and +6. In infants, -12 and +4. Sensitivity should be started in the mid-range, about 5, and adjusted to achieve maximum synchronization with the patient's respiratory efforts. Respiratory synchronized works similarly to positive pressure mode of pressure support in CPAP. As patient's inspiratory effort initiates negative inspiratory support phase, and end of inspiration begins the exhalation phase. So the patient's breath timing is driving the cycle timing of the device, fully synchronized with the patient's own respiratory pattern. The patient's spontaneous rate or backup rate set determines the total frequency. No IE ratio is set in respiratory synchronized. The mode synchronizes with the patient's own timing of both phases of the respiratory cycle. If apnea should occur, the RTX defaults into the backup rate at set pressures. Airway triggering should be selected for patients who are unable to synchronize with Kuros sensing. Airway triggering can be achieved by airway pressure sensor tube connected to a nasal cannula placed at the patient's nostril or mouth. Tape the sensor tube inside a tracheostomy mask and over the opening of the tracheostomy, or use a standard T-type airway adapter with pressure sensing port connected directly to the tracheostomy or endotracheal tube back to the device. Pressure waves on graphic display screen must be visible and consistent to ensure reliable and consistent triggering. Additional precautions and considerations of respiratory synchronized airway trigger is more sensitive. Starting sensitivity set at 5 and adjust for maximum synchronization. Kuros triggering is better for extreme respiratory effort, such as ARDS with high rates. Starting sensitivity set around 3. Trigger percentage reading should be 85 to 99%. Adjust your sensitivity to get in this range. Prolonged periods of less than 85% generally indicate need for more sensitivity. Prolonged periods at 100% indicate that it's a potential for auto-triggering. Monitor patient closely and decrease sensitivity if indicated. Additional precautions and considerations. The minimum backup rate is 6 per minute. The maximum backup rate is 60 per minute. Set backup rate to about half of what the patient is breathing after settled on support, usually as a safety net for apnea or hypoventilation. The shallower the patient's breathing, the more sensitive the trigger should be to capture their respiratory efforts. Respiratory synchronized is typically more comfortable for patients than respiratory triggered. Secretion clearance. Secretion clearance, vibration or oscillation, physiologic effects. Used as a chest physiotherapy tool to enhance clearance of secretions, the vibration phase creates a high-frequency oscillatory waveform to loosen, thin, and mobilize retained pulmonary secretions. Frequencies may be varied for maximum effect. Vibration is followed by a cough cycle that produces the key elements of a good cough. A deep inspiration followed by a high-flow expiratory maneuver or cough. Indications: retain secretions from all etiologies, including but not limited to cystic fibrosis, bronchitis, secretion-related atelectasis, bronchiectasis, asthma-related secretion retention, neuromuscular illness with a weak or non-effective cough. Secretion clearance starting settings, vibration. Recommended setting of initial frequency of 800. For more tenacious secretions, decrease the frequency as tolerated. Usually 600 to 800 offers the best combination of effectiveness and tolerability. Frequencies greater than 800 may not provide as thorough mobilization and thinning effect on secretions, but may be more comfortable for a patient needing to grow used to this therapy or for smaller patients. Less than 600 may be too intense for most patients, although some prefer the high intensity. Starting settings, vibration continued. Pressure setting affects the intensity of the oscillatory wave produced. Settings of the vibration pressure control, -5 to -20 for infants, -15 to -30 for pediatrics, -20 to -40 for adults. Set the duration of the oscillation 2 to 4 minutes for infants, 2 to 5 minutes for pediatrics, and 3 to 5 minutes for adults. The IE ratio is static in the vibration phase of the secretion clearance mode and therefore does not need to be set. It automatically cycles from the vibration phase into the cough phase at the end of the set duration. Cough. The RTX supports the components of an effective cough. Start the cough on a rate of around 20 to 40 cycles per minute, more if patient prefers or if you achieve a better effect. 24 cycles per minute is generally recommended for alert patients because it allows good rate and predictability. As long as settings or alarms are not displayed on the right side of the screen, the graph should display each cough in the same position in the sweep as prior coughs. Patients can be coached to huff or use whatever cough effort they have and coordinate with the positive phase of the cough assist for greatest advantage. Slight fingertip pressure on the upper portion of the cuirass coordinated with positive pressure cycle of assisted cough can generate even greater cough flows during the cycle. Settings for cough assist for the assist cough mode are -25 plus 15 or to as high as -35 plus 30 based on size and tolerance and effectiveness for the patient. Set desired time. Typically, the cough phase is utilized for 2 minutes, but can be lowered or increased for patient tolerance and efficacy. For most patients, set time to 2 minutes due to the ramp effect. Cough intensity will grow with time. Thus, less than 2 minutes may not create adequate cough flows. Shorter time intervals can be used, however, for patients that are unable to tolerate the full 2 minutes of cough, so they get some benefit. Longer times are rarely recommended. A whole cycle is considered one vibration cycle followed by one cough cycle. Then the device repeats. Set your repeat count to create the desired length of treatment. For example, a 6-minute cycle, which may be 4 minutes of vibration, 2 minutes of cough, repeated 5 times yields a 30-minute secretion clearance treatment session. 20 to 40 minutes total is recommended. For patients on a high level of ventilator support or high minute ventilation requirements, shorter periods of oscillation and longer periods of assist cough in the balance will support higher CO2 clearance needs for that individual. In some patients, occasional breaths with a bag and mask may be needed during oscillation if dyspnea or O2 desaturations occur. BCV automatically cycles into vibration at the end of the set duration or to standby at the end of the final full cycle. BCV goes to standby at the end of the final cycle and must be manually returned to support mode if needed. Modes of ventilation, setting selection and adjustment. In this module, we reviewed available modes on the Hayek RTX, the physiologic effects of each mode, indications for each mode, starting settings for each mode, precautions and considerations. Thank you. That concludes Module 7.